What if we move to a sustainable society?
What if gas were $10 a gallon?
What if everyone voted?
What if everyone had health care?
What if?
What if?
What if? What if?
What if?
What if?
What if?
What if?
I'd like to start and thank our sponsors for this evening, the Iowa City Public Library, the Johnson County Livable Communities, Iowa City Area Chamber of Commerce, the League of Women Voters of Johnson County, the Iowa City Press Citizen, PATV, and Hills Bank and Trust. And I think you can see from that list, again, a nice group of really community-engaged types of organizations that we really like to partner with. So tonight we're going to be talking about what if everyone had health insurance. And again, the goal of this is to engage in a discussion about what that might mean, what are some of the both intended and unintended consequences were that to happen. And we're going to start the evening with a little bit of an overview of what is the Affordable Care Act, some of the pieces and parts, lead into some other discussions about aspects of prevention, healthcare integration, and behavior change, which are really important, that we'll be conducting and sharing with some of my colleagues from the Public Policy Center. So we're going to start with, as I mentioned, an overview of the Affordable Care Act and what's driving this whole discussion. Why are we putting all this time and energy, political capital, into this whole discussion about healthcare reform? Talk about some of the pieces and parts of the Affordable Care Act, and really I like to think of this as two different aspects of it. One is the insurance coverage, which, as mentioned in our title, that's what we're going to be focusing on, but there are also some really important aspects about change in the delivery system, which we'll be touching on. We may or may not get into the depth, but something that we could if people are interested, and then allow plenty of time for discussion. So when we talk about why are we even doing this, all of us who are going to be speaking tonight are what are called health services researchers, and we study the healthcare delivery system. One is in particular more on the behavioral side, but these are the things that we look at: cost of care, access to care, and quality of care. So first question for the evening is, how much do we spend on healthcare in the United States? So how many of you would say A? How many B? How many C? How many D? Okay, going back to third grade, when you're not sure, always pick C, right? So we spend about $3 trillion on healthcare in the United States in any given year. And the quality component of this is, according to the Institute of Medicine, about 1/3 of that is considered waste. And we could spend the next hour and a half describing what that might mean and what waste is and all of those kinds of things. But basically, it's money that's being spent that doesn't impact the health status of the individual in which it's being spent on. And from an international health perspective, many of you are aware we spend way more than any other country, whether it's in terms of cost per person or cost as a proportion of our gross domestic product. And why is that important? Why do we care? Because that produces jobs, that spurs the economy, it's 1/6 of the economy. What's the difference? We spend 16, 17, 21% of GDP on healthcare. What does it matter?
It's a dollar you cannot spend on anything else.
Right, what economists call opportunity cost, right? It's a dollar that you can't. So if you want to spend on defense or spend on environmental policy or whatever, we're spending that on healthcare and you can't spend it somewhere else. Also, we're in a global competitive marketplace. And so Chrysler or Ford that's trying to sell cars against the Japanese and the Koreans, they may have an extra $500 of that car that actually is just related to the health care of the employees that made it. And so it also affects our international competitiveness in that way. Good. And that money isn't spent equally across the population, right? We don't all have the same amount of healthcare spending during the year. 1% of the population actually spends about 20%, 27% of all of our healthcare costs, and 10%, 69%. And when you think about it, yeah, that kind of makes sense, right? And who are these really high cost, high utilizers? What kinds of people?
Sick people.
Sick people. Versus all the healthy people that are here.
Elderly.
Elderly, to some extent, right? Not uniformly across seniors.
The terminally
It could be that end of life year, right? And we often talk about how much we spend with a large proportion, but that also means we're looking backwards a little bit, right? You don't always know that's the last year of life going in. If it's Aunt Minnie and she's 98, then yeah, you know, we kind of, okay. But there's other ones, could be a cancer patient or trauma or something, that there could be somebody that's made it in the same kind of situation that this person didn't. What other kinds of folks?
Chronic.
Pardon me?
Chronic.
Right, a lot of people with chronic illnesses, right? And multiple chronic illnesses. And they'd be multiply, both physically and mental health chronic illnesses, right? One other big group.
Obese.
Obesity, which again, you could say is chronic illness. People with disabilities, right? And children with special health care needs. Those are the folks in which we're spending a lot of that healthcare dollar, and again, unevenly. And for the first time, really, we're starting to focus on who are these people and how do we get to them sooner. And that's one of the things that's happening. We're trying to figure out how to do that. But a lot of this energy is being spent on financial access, meaning insurance coverage. And that's because we have about 50 million people in the United States that don't have health insurance at any particular point in time. And recent numbers just came out, it increased to 32 million of people who are underinsured. And what do you think underinsured means?
High deductible.
Just having basic catastrophic insurance, like people who just have major medical insurance, and their insurance doesn't actually cover all of their needs.
It could be catastrophic or major medical, right? But it's basically they don't have enough insurance if they were to have some sort of a catastrophic event. And unfortunately, most people don't know that until the time that it happens. There actually is a lot of people who think they have pretty good coverage, and then all of a sudden they have some sort of an issue, and then they don't have the coverage that they thought. And one of the things that most people are surprised about the uninsured is 80% of them are working people and their families. So it's not that these people aren't trying, it's the way I described it, they're working at the wrong job. So you could have two printers doing the exact same thing, working at companies right next to each other. One gets benefits and one doesn't. And what does it cost for health insurance in the United States for a family policy? Anybody know what an average family policy costs? Other than a lot.
$3,000 a year?
I'm sorry?
$3,000 a year?
Three? That would be nice.
10 to 12.
Yeah, actually about $16,000 a year is the average for a family policy right now. And among the uninsured, even though they're working, they tend to be lower wage and make about 2/3 of them are making $50,000 a year or less. And so you don't generally have $16,000 in disposable income sitting around to purchase health insurance, right? And these are what the uninsured in Iowa look like. And the majority of them, about 3/4 of them, are going to be eligible, or were, now that the open enrollment period is done, for financial assistance either through the Medicaid expansion or through the health insurance marketplace. And about 1/4 of them are going to be over $400,000 a year and are not going to be eligible, or they're undocumented, which is about 5% of the uninsured in Iowa and aren't eligible for subsidy. And then that quality metric that people often focus on is that we spend the most, but we have the lowest life expectancy and infant mortality. But as we're going to be talking about later, you've got to be very careful when you're making that kind of a leap, because these things, when you look at what really relates to life expectancy or infant mortality or some of those measures, it's much more than the healthcare delivery system, right? And that's what we're going to be talking about. Insurance is only one piece of this, and so you've got to be real careful with that. That doesn't mean that we don't have some issues, but it's not quite that straightforward. So the Affordable Care Act first was passed in March of 2010, and again, it has these two major components between the insurance expansion and the delivery system change, and we're going to be focusing on the insurance, but it's so complicated, this is what it feels like to many people, and that's the president over there saying maybe I should have been a little more specific, and it isn't really a specificity issue, it's just the complexity, whether it's a large transportation bill or a Wall Street reform or something like that. You know, it's very tough for people to get their arms around that, and it's obviously very political. And we're here not to talk about either the partisan nature of this or this is the greatest thing or not, really just to kind of help tease this apart so people can understand it better. But it's the next iteration from an insurance coverage perspective to covering the gaps. So in the United States, we've never determined that we want to cover everybody like in most countries with insurance. We started during World War II when there was a wage and price freeze on, and we started offering health insurance as a benefit. It started to catch on and people liked it. We had more collective bargaining during the 50s, more unionization, and then the government decided to allow employers to write it off of their taxes. Then in 1965, we picked up, again, two of the bigger cost groups that were left, seniors and people with disabilities, through Medicare and Medicaid and low-income populations. 1997 decided to cover low-income kids of the working poor, with the Children's Health Insurance Program. Now we're reaching out to those uninsured single adults who weren't Medicaid eligible before, and people who were in the single individual and small business market insurance, who their costs were going up sometimes 10, 20, 30% a year. If they had a pre-existing condition, they weren't able to get coverage, they could get dropped if they get sick, some of those kinds of things. So that's what this part of the expansion is really designed for. How much is it going to cost? Anybody want to bet on these numbers that these are going to hold? How good are we at projecting these? The interesting thing is the CBO just came out with a report this week that looks like the numbers are actually going to be lower this year than their original projections. So this year, the cost for the ACA is about $138 billion they're estimating, about $5 billion less than they were originally estimating. Total cost for the next 10 years, about $780 billion, about $164 billion than they were originally estimating, because the plans don't look as much like employer-based insurance as they thought, meaning there's more narrow network plans, meaning fewer people you can go to, but it was a way to hold down those costs, so the overall costs are less, but it's not going to impact the deficit. In fact, it's actually going to help the deficit go down because of some of the cost shifting that's going on. So it's going to be financed through a combination of payment mechanisms we can talk about if you want to, and of course the famous 10% tanning tax, which we don't want to forget. But there are about 50 different components of the Affordable Care Act that went into place already prior to January 1, including things like covering kids up to age 26 on parents' policies and a number of very popular items. But now the individual mandate kicked in, and that's the thing that people aren't real thrilled about, right? Even if it doesn't affect them, only about 6% of the population the Urban Institute estimates is affected by the individual mandate. People don't like that feeling like they're being told what to do, right? But in addition, you've got the Medicaid expansion and then the health insurance marketplaces. And why is there the individual mandate? Why do you think the government is making everybody buy insurance?
To increase the pool.
Right. It has to do with risk pool, right? Is it the government that's driving that? No, it's the private insurance companies that said, we're going to be driving people into the private market, into these health insurance marketplaces, and if you want us to get rid of pre-existing conditions and annual maximums and dropping people when they get sick, the only way we're going to do it, and it's the same thing in Massachusetts when Mitt Romney did Romney Care there, is you got to bring everybody in, because if only the sick people buy it, it can't work. And so it's not the government that's doing that. But the end result in Iowa is that we've got Medicaid, and this for kids isn't going to change much. You can have Medicaid up to 138% of poverty, Children's Health Insurance Program in Iowa called Hawkeye up to 300%, and then they can go and buy subsidized insurance in the health insurance marketplace, private insurance up to 400%. And then for adults, this is where the big change is because of those single adults that weren't eligible for Medicaid, lower income. We had the Iowa Care program, but now that's getting transitioned into what's called the Health and Wellness Plan, and that's for people up to 133% of poverty. And then from there, they can purchase subsidized insurance in the health insurance marketplace. So the health insurance marketplace component, that's the healthcare.gov that you all have heard about. And yes, there were a lot of hiccups with the original website and people trying to enroll. But that was the idea, again, going in to purchase private health insurance. In Iowa, these are the plans that are available. There are only 2 statewide plans, Coventry and Coopportunity Health. Then there's 2 regional plans, Gunderson and Sanford Health. And there's really one main dental plan, which is Delta Dental. The others haven't really become that much of a player. So the people can go in and choose from these different plans, and depending on what's in their area. All of them have to cover all of these essential health benefits. And so it's a very rich plan, if you will. And then they choose what are called these metal levels of plans. So either a bronze, silver, gold, or platinum, and that has to do with how much of your out-of-pocket costs are going to be covered based on which plan, and obviously your deductible, your cost will be higher, your premium, if it covers more of your out-of-pocket cost. But the subsidy level, which is based on your income taxes, won't change. So based on your income, if you get a subsidy of, say, $300 a month, regardless of which level, that stays the same, and then you choose which plan, which network, which total cost you want. And now this was up until April 1st. Okay, that's when the open enrollment period ended. It's going to start again in November. So what we know about the impact so far, numbers just went up to 8.5 million that have purchased plans either through the federal or state exchanges. Another somewhere in the neighborhood of 5 to 9 million are eligible in states where they have the Medicaid expansion, or were eligible for Medicaid before in states that didn't have it and actually enrolled what they call a woodwork effect, people coming out. There was a lot of concern, do we have a number of young people? And it does look like that the age distribution was pretty good. And it's really more important, not just the age distribution, but the health distribution. It wouldn't have helped if you had a whole bunch of young, sick people. You needed young, healthy people to mix with the older, healthy people, or sick people. One of the big issues that are happening on the delivery system side, we're not going to spend a lot of time on this today, but it's this development of accountable care organizations. And this is really something that's changing the delivery system side pretty drastically, where it's causing a lot of the providers to group together into, right now in Iowa, you've got two real competing delivery systems with Unity Point, which used to be Iowa Health System, and the University Alliance, which is the University Hospitals, Mercy in Cedar Rapids, Mercy in Des Moines, and Genesis in the Quad Cities, and Mercy in Mason City. And so they're really going head to head. Cedar Rapids front and center. You've got Mercy and St. Luke's across the street from each other in different networks competing. You know, we'll see whether this will work to actually hold down costs and improve quality. You know, ultimately though, the implementation is going to be critical. A lot of things are going on. Educating these consumers about the next level. What does this mean? Especially the ones that didn't jump in yet. What we know from some of our research is these are people that don't know a lot about the Affordable Care Act. They don't have a lot of experience with health insurance. They're very skeptical about what the benefit is. And so, you know, it'll be interesting to see what happens over the next 6 months leading up to the next open enrollment period in November about whether people see this as a good thing or not. And, you know, the talking heads that people tend to defer to when they get overwhelmed from the complexity, we'll see again how that sort of plays out. Cost is really going to be critical, but this is a long haul. This isn't like a one and done kind of thing. So what if everyone had health insurance? So this is the way, and this isn't meant as in a partisan way at all, but this is the way I kind of like to think about the options if you were going to try to address those issues that we talked about earlier. So when you think about the $3 trillion in cost, the 50 million uninsured, and then the quality issues, that 1/3 waste issue. So how could you approach it? And this time what was interesting, during the political discussion, there was nothing, if you will, left of the individual mandate on the table. And that was one of the reasons, in my opinion, it was able to get passed. But during the Clinton reform era, for example, all of these things were. So if you would, on the left, you had a national health service, would be like in Great Britain, where the government owns all of the facilities, most of the healthcare providers are government employees, and the insurance is government. You start moving to the right, Canada has a national health insurance system, like a Medicare for all, but most of the providers are private. The Clinton plan was to be an employer mandate, which didn't pass, but that was going to put the onus on the employers to cover people. This is an individual mandate, which is actually a slightly right-of-center approach, which says that the individual has a responsibility to take care of themselves, and it was a way to keep the private insurance companies in the game, which they very much want to do. They didn't want a government-run type of system. Then you kind of move to the right from there, healthcare savings accounts, selling insurance across state lines, or we really don't need to do anything. And so I think it's important just to kind of think about those options and what the actual context is. Not that that makes it good, bad, indifferent, but just sort of where that sort of falls in this. And one of the interesting unintended consequences that came out recently in another CBO report is that in terms of employment, and both sides jumped on this, and that was that there was going to be 2 million people who will quit, stop looking, or reduce their hours because of the Affordable Care Act. So where do you think that comes from? And is that a good or bad thing?
People who are employed because of the health benefits.
Right, there are people, you think about the university, and I think of about probably 20 to 25% of the staff at the university are working for benefits, right? They come from small towns, might have a spouse that farms, or whatever the situation might be, and the only reason they're working is primarily for benefits. And if they no longer had to do that, you know, what that would do, there would be a disruption to the economy. But the interesting thing, the net result is that there was no increase in unemployment, is that this was shifting mostly by preference. And so the people who opposed the Affordable Care Act said, no, 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 it's going to kill employment and all this kind of stuff. The people who are supportive were saying, no, this is going to increase entrepreneurial activity and people could go and do what they wanted and not have to do what they felt like they had to. So it's one of those things when you think about what if everyone had health insurance, that's something to kind of consider. What would the end result? How long would it take for that to sort of shake itself out in the economy? In the end, would that be a good or a bad thing? So, question open up to you then. Should there be a right to basic health insurance in the United States?
Yeah.
And If not, why not? And if so, how should it be provided and how should it be paid for? So how many of you would say that there should be a right to basic health care? Health insurance. Health insurance different than health care, different than health, as we'll be talking about. Very distinct. How many of you not so sure? Okay. Those of you who do believe, what do you think the right mechanism for it should be?
One payer system.
Government.
Okay, single payer system, government.
Single payer like they have in Canada, isn't that government?
It is at the provincial level there, rather than, again, a countrywide, but yes, yep. And what do you think the advantage of that is?
Well, everybody has it, for one
Yeah,
thing.
everybody has it.
Everybody pays into it through taxes.
Right.
It probably makes it simpler for the healthcare provider. I'm guessing, I don't know for sure.
Well, that's my personal guess on when I think it will happen, is when the healthcare providers get tired of all of these multiple payers and multiple rules and multiple formularies and all this kind of stuff, and they're willing to take a chance that it might mean a little bit less, but it'll be simpler. But you don't know that for sure, right? You'd be betting on that it would be, but I think that's one of the reasons it's happened, because I don't think people are convinced that that's true yet, from a provider perspective.
Would care be rationed?
Would care be rationed?
What was that?
Rationing? Rationing?
Would care be rationed? And
You always hear about that in Canada, right?
right, you hear about in Canada, and often what you sort of hear is that they have better access to primary care, but maybe not as much to specialty care, right? Do we ration care now?
Yes, by wealth.
Right. But yeah, how do we do it?
By wealth.
It could be by wealth.
Location, access.
Right, right, location. Access is actually a multi-dimensional issue, right? Again, not just financial. There's a lot of other language, culture, transportation, distance kinds of things, right? Is that rationing though? I think what Suzanne's talking about, something a little bit more overt. Could there be rationing in that sort of a system? If we have a single payer.
There's some level of rationing right now with private payer that denies surgeries and procedures on a regular basis.
Sure, there's some rationing now in terms of what insurance will and will not cover. So we often think of it, employer-based health insurance is sort of the gold standard, right? But why do employers provide health insurance when they don't have to right now in the United States?
Why don't they?
Why do they? Those that do, why are they doing it?
Keep your employees healthy and working.
To some extent, keeping them healthy and working.
To compete in the labor market, to hire the skilled labor.
Right, much more for a recruitment and retention issue, right? Does the benefit package that an employer offers have anything to do with the health of the employee? No, not really. It's based on what they're willing to spend for that policy, right? Or if they're self-insured, most larger companies are, what they feel like they need to offer to be competitive in the market, right? But we often think that it should be related, just like you're talking about that rationing. Well, my insurance won't allow me to do this. Well, that's because it's, again, they won't pay for that. It's not that you couldn't do it, right? But that feels like rationing. And many people can't afford it beyond that, so then in essence, it's rationing.
I'm not naive, some of them pay it because of a moral issue.
Sure, I mean, there's gonna be some employers that are doing it because they think it's the right thing to do, right? But there's still gonna be some sort of a business aspect to it, right? But you're right, especially some small businesses do it for that reason, because more small businesses than large businesses don't, because it's gonna be they tend to be on smaller profit margins, tend to be a larger proportion of their cost. They can't self-insure as easily, things like that. For those of you the few of you are willing to say, maybe not, why not?
I guess I prefer like a moral obligation, or I prefer it to be looked at as something that society should give rather than you have a positive right to expect to receive it. right sounds too much like somebody could knock on my door at 3 a.m. and say, you have to give this to me.
Okay.
How many people is that?
Yeah, so I was gonna, could you repeat that one more time? I'm not sure I picked up the first part.
Sure, I guess I would prefer it, maybe society has a moral obligation to ensure that everyone receives care. I see, it's a difference between a positive right and a negative right to me. I'm just...
Okay. So moral obligation versus a right to you means something different. And how would you see that different in terms of the implementation?
I don't necessarily know that I would see it. It's more a matter of semantics for me.
Okay.
Like I said, it's more an issue of if it's 3 in the morning and I'm a physician, I don't want someone knocking on my door and saying, this is my right, give it to me.
Okay, now again, we're talking about a right to health insurance, not necessarily a right to health care, right? Because those could be very different in terms of that knocking on a physician's door at 3 in the morning. Yes, that's a different issue.
So a right to health insurance is not the same thing as saying that everyone has to have health insurance. It just means that you have the right to have it if you want it. So there's a difference between those two things.
So
at this point in time, everybody can have health insurance. They might not be able to afford it, but everyone has the right to participate in political campaigns, even if they can't afford the millions of dollars that it might take to participate.
okay, so everyone has the right now, they just can't all afford it. Does that equate to folks?
Is there anyone who wants to buy health insurance who was told you're not allowed to have health insurance? It's separate from the financial issue.
Right, separate, well,
okay. There's a good example.
okay, so the example is, well, someone with a pre-existing condition can't, regardless of how much money,
Maybe not as a standard.
maybe not how much, any amount, right? Because you do have people, I mean, we know there are people who don't believe in insurance and don't believe in the concept. So I don't think what we're talking about is forcing somebody to have something that they don't want to have. But among those 50 million people who are uninsured, we know most of them would like insurance and just haven't had the ability or financial ability to get it. Right? So I think that's more what we're really talking about in terms of that.
Who doesn't want to have health insurance?
Well, not even just people without money. When we've looked at that question before, there are people that, I mean, number one, if they feel like there's some sort of a trade-off for their children versus them, that they will definitely give it to their kids versus themselves. There's people that have sort of been able to get by without, is sort of the group that we've looked at. Because we looked at this in terms of, we did a study looking at enrollment into Medicaid and the barriers of getting in. And there were some people that, you know, just kind of kept pushing through, yeah, sacrificing. And again, there's just people that they don't feel like they need it. They don't necessarily, there's a stigma associated with, say, public insurance if they're lower income, that they don't want that. There are people who would rather have, you know, be into a lower end private insurance than public insurance. I mean, there's a lot of, depending on once you start getting into what type, then that can make a difference in terms of how people view it. And again, we're sort of talking as if having health insurance is something consistent, right? And again, there's a spectrum of policies of types and coverage and amounts and all those kinds of things too that you really need to get into. But it's, why do you think we haven't had it to this point? If everybody here is all for it, and why has this not been sort of a political winner? Here we want to give people insurance. Here we want to do the right thing. Why is that not going on? Lobbyists for who?
People who want to
Insurance
have it.
Well, but we're driving more people into the insurance companies, right? Even though at times they sort of make it sound like they're not interested, but.
Maybe some of the care providers, because there's control over what they perceive they can do.
Could be some of the care providers, but actually this time the physicians, the AMA, for example, was in support, but not, again, not necessarily universal. But it's just something interesting to think about. Everybody here is kind of for it. Seems like a really good thing. People want it, yet we can't quite get there in a smooth way, right? So we're going to now switch, and I'm going to introduce my colleague, Dr. Betsy Mominy, who is going to talk about health insurance, health status, and how that plays out into healthcare integration and some of the things we're going on in healthcare delivery systems.
It's kind of like gun control.
Well,
Could be.
everybody wants it. I don't. I like my gun. And I actually do like my gun, so I'm sorry about that, but I do. What I'd like to ask you is, you all thought everybody had a right to health insurance, but do you think everybody has a right to food?
Yes.
Really?
Yes.
So what if you had to decide which people needed food or health insurance? Does America have enough money to buy it all?
Yes.
Does it? Where would it get that money from? Closing loopholes. I love that. Gun tax, right? Text that woman up front. She needs a gun tax. That'll help us all get more money. How else would you get it? What would you trade? What would you out there be willing to give up tomorrow so everyone could have health insurance?
Junk food. You eat healthy food, you don't need as much health
There you go. If you have healthy food, you don't need as much health insurance. So you're giving up choice. I don't get to eat an Arby's burger anymore. Is that something you really want to give up? Do you want to say no more Monster drinks? College students in the room? Are you ready to say no more Monster? Where's Paul Hanley? Are you ready to say no more Monster drinks? So there might be a whole group of us who are willing to give up Monster drinks because we think we could use the money of an energy drink to help fund it. But there might be another group that doesn't want to give that up. Is there anything we can all agree on? Probably not. So that's why this becomes so political, right? Is because when you start to talk about how you're going to fund it and who's going to get the money out of it, then you start to understand that everybody has a different perspective. And we get another offshoot of that is what Dr. Pete often calls the disease of the month club, which means people who have cancer want you to put all the funding that you can into cancer treatment. People who have diabetes want you to cover nutrition and healthy food. People who have coronary artery disease want the latest cardiac stent. And somehow we've all got to decide, when you say we want health insurance, what's in that package, right? Are we going to cover all well baby visits? I don't know, if you're a kid in Alabama, you're probably not going to get one. Are you going to cover high blood pressure medication for me who eats a tablespoon of salt on my food every night? Are you going to pay for those new lungs for the guy who smoked cigarettes for 50 years? No, I hear no. But if I were the guy who'd been smoking for 50 years, I'd say yes, right? And if he were my dad, I'd say yes. Or if he were my brother, I'd say yes. So it all becomes very personal to us. And probably one of the most, oh, Pete left me up here not knowing how to switch the slide. I'll push a little bit. Oh, look, there it goes. Wow, it's good I got a PhD. So probably the most interesting thing about that whole conversation is how much difference does medical care make in our health. We all find it as incredibly important to us, and yet when you look at this chart, we all see what we all kind of thought, don't we? What makes the most difference in your health? Behavior. Behavior, behavior, behavior. Go to the mall on Saturday morning and watch what people eat. Go out by the hospital at noon and watch how many people who are in healthcare are smoking. Come watch me sit on my fat back end every night and not exercise. If we all paid attention to our behaviors, we might not need as much health insurance as we have, right? We might not need hardly anything. Maybe that catastrophic coverage in case you have a horrible accident or some horrible disease that no one anticipated might be fine, might be all you need. Genetics, it's a huge deal. Maybe we should put some more money into that genetic research and not make me have to behave, but just genetically alter me somehow. I'd love to be altered. Social environment, how often do we care about the fact that if you're poor, you're more likely to be in a neighborhood where you're going to have traffic and noise and particles and no grocery store and Monster drinks on the corner? and cheaper chips than apples? I don't know. If I've got the convenience store on that corner, I'm darn glad I don't have to sell apples. I probably make more on chips. Physical environment, and then 10% access to health care. We're here tonight talking about coverage for something that makes 10% difference in your ultimate health. That always just astounds me. Oh, right, I have to remember again. I'm sort of ADD, so I forget very quickly. And then how are we spending our money to achieve our health? 84% is going into the 10%, and then other is 13 in public health. If we ran our stock portfolios like this in this country, we'd be poor. You know, we'd have nothing left. How many of us would take our money and put it where we're only getting a 10% return? I just took $84 and I threw it in the pot and I got 10 back. That doesn't make any sense to me. So we have to think always when we talk about health insurance that we understand it from a big picture when someone has a lot of costs. Because you hear a lot about people going bankrupt because they have health care costs that they can't meet. So that sort of contributes to their bankruptcy and their forfeitures. You would all probably know someone who has had a terrible experience in their health care and they've had to have a benefit, or they've had to sell their house, or they couldn't get a car. Maybe it's you, maybe it's me. But can we cover those folks cheaper? Can we do it better? And if not, what would you be willing to give up? I'm always the giving up person. So here are our challenges in America today. The prevention of chronic illness, that's high blood pressure, right? That's exercising. That's less salt. That's eating less fat. That's not going to Arby's, I guess. Sorry, if there's an Arby's owner here, I apologize ahead of time. Obesity epidemic, we've all heard about that. And that's particularly bad here in Iowa, but if you want to see where it's really bad in the South. 30% of people down in Mississippi and Alabama are obese and have diabetes. The other place I think it's really interesting that it's kind of high is Alaska, but I've decided that's because it's so cold there that people just need an extra layer on them. Healthcare delivery and reimbursement system that emphasizes diagnostic and treatment services. So how do we do that? How do we pay for those things? And who does those things? And then these things have led to medical homes and health homes. I don't know if any of you have heard of those, but we're really thinking a lot more about what we think of as the doctor's office or the clinic as more of a place that coordinates your care across lots of different options and pulls in all the things like a nutritionist and a physical therapist and perhaps a behavioral health specialist, which we'll talk about a little bit later. So keep thinking about this as we move through the presentation and start to make some decisions in your mind about what really matters in this country and how does it matter. And now me again, right. I hate that. Okay, I'm going to skip this question and go straight to health integration. So we talked about primary to medical homes. Some people call them a patient-centered medical home. Sometimes we call it an integrated care home or integrated health home. It's the idea that your doctor's office or your provider's office, it could be an ARNP, an advanced practice nurse. It could be a physician assistant. That in that office, they're going to coordinate all sorts of care. So we need to understand that in America, right, when insurance started, they covered a lot of physical illnesses because we could kind of predict what the cost would be. If I had to treat pharyngitis, I knew what antibiotics cost, I know how long you have to take them, and I know about what it costs. We didn't know that about depression. We didn't know that about schizophrenia. In fact, we had horrible ways of treating it. And nobody wanted to actuarialize the cost of mental health because there weren't clear treatments at that time. So we got a kind of a bipartite system where we paid for health insurance and we got physical care, our mental illnesses were not treated effectively and people weren't paying for it. And so we saw families not admitting to it, not treating it. More recently, we've seen parity laws come into place. So you have to cover mental illness at the same rate that you cover physical illness. So people can get treatment for depression. And we've now found out, right, that the younger we treat people for their mental illness, the more positive is their outcome. In fact, if you can treat a teenager when they're in their young teens for depression, chances are they will have very little ramification of that later in life because you get them treated, you help them cope at a critical time. What we want to do now is get behavioral health into doctors' offices. We want to bring psychologists, psychiatrists, licensed counselors into the doctor's office, but it's so hard because what do you call somebody you're treating if you are a mental health specialist? What do you call them?
Client.
Right, they're a client. What are they if you're a doctor?
Patient.
Yeah, right. So, you know, Dr. X is talking about his patient or her patient, and Counselor Y is talking about a client. And they might not even realize it's the same person. Don't tell them. What else happens? How long is a visit to your counselor?
50 minutes.
Correct, that's perfect. 50 minutes and 10 minutes for writing a note down. Let's turn that around. How long is the visit to your doctor usually?
10 minutes.
Right. And if you talk about anything to do with mental health, your doctor goes crazy, right? It's like, I don't want to talk about that. Don't you have a rash? I know what to do with a rash. You know, it's classic. And if you're the kind of patient that comes back 3 times in a month, you're a problem patient. If you're a counselor's patient, how often do you come back? Yeah, at least once a week, sometimes 3 times a week. So what a different way to look at the world. This idea of you as a person, as a whole, and this idea of you as kind of, well, you're a problem. You've got a cold, you've got this, you've got that. I'm doing a well visit, I'm going to do a colonoscopy, we'll look at some tests, we'll see what's wrong with you. Just recently, we've started to talk about how to integrate these things. One of the biggest problems stopping it in America today is the fact that the electronic health records for these 2 systems do not meet. They are completely separate. I can't put an electronic health record into an office that will serve both the docs and the counselors. Now that's actually a lie because we've done that in our clinic, but it's hard. It's not an easy thing to do. And most people don't want to do it because it's so different. The way you take notes, if you go to a physician's or a medical doctor's office, the note takes up this much space. There's like 5 sentences. If it's a long one, it may be like this long. Counseling notes, they're huge. They're talking all about your experiences, what you've got, what the plans are. But one of the great things is if we can accomplish this integration, look what you can find. People with mental illness of any kind are more likely to have a chronic illness. If you can treat both of those together, you are going to, wait, there. You're gonna, sorry. I get ahead of myself. You are gonna save money, which of course in America is what we all care about, right? Because we're capitalists in our hearts. So in one program where they integrated mental health services, substance abuse services, and please remember when I say substance abuse, I'm not just talking about somebody who drinks too much or does illicit drugs. I'm talking about people that you all know who are addicted to prescription medications, because that's a huge problem in America today, particularly among our seniors or people with chronic pain. The addictions are huge. We've got people, you can find people taking 400 Oxycontin in a month because of chronic pain. So if you are treating their abuse, substance abuse, their mental health, and their chronic illness, in this program, 170 people in an integrated program, $213,000 in savings per month. Reduced nights homeless, which is really important actually. Fewer hospitalizations, fewer nights in a hospital, so less ER use. So when we can coordinate and integrate care, we're able to help people meet a whole person kind of need. So now, my question is, and I'd love to know your answers, I really would, though I like to hear myself talk too, is what would it feel like to be in an office that treated you like a person? What do you imagine that would be like?
Refreshing.
It would be, yes. And you wouldn't have girls up front. There's nothing makes me crazier when people say, well, you know those girls up front in the doctor's office. I'm like, they're 80 years old. They're not girls. They're 60. We've got one that's 67. She's not a girl anymore. But what would it be like? How would you feel? How would they treat you differently? Yeah.
More willing to like disclose, like sensitive topics, like say substance abuse or something personal that could affect your healthcare.
I like that.
Less misdiagnosis.
Perfect.
Less problems with diagnosis, especially in terms of mental health, because you get a whole picture.
Yes. Perfect. Yes.
I think more motivation for the person who goes there for care to take personal responsibility.
You've hit on a very key piece of integrated healthcare, and that's the health coach. So we're training nurses and allied health professionals now to do work with talking to people and helping them understand how they can take responsibility for their own health care. What else might we see if we had a more integrated system? We would. Actually, that's so funny. We would see happier providers. We did this in our clinic out in Amana. And one of the first things that happened is the doctors that were treating our patients came to me after we put a good counselor in. And we actually put a counselor into a room without any appointment. So docs could just walk over and say, you need to see this person. And that's what they did. And the first time, I had one of my doctors who thinks he can pretty much do anything, which isn't that unusual really, but he, I love him very much, but I'm actually married to one of them, so I have to love him very much, or not. But what happened, I'm sorry, I digress. But what happened is that this doctor is sitting with a patient that he's been trying to counsel through a difficult marriage situation and treating for depression at the same time. Unsuccessfully on both. Because medicine never works by itself for mental illness. The most effective means of treating is cognitive behavioral therapy, and medicine always has been proven to be most effective. You have to merge the two. So he's sitting there trying to do this and suddenly remembers, wait, there's a counselor right down the hall. Walks the patient in, introduces the patient. Our counselor spends an hour with the patient, is able to work through some issues, give them some homework, help understand why they need to take the medication the way it's prescribed. And the doc is walking around like on cloud nine because that doctor just got rid of a problem they couldn't solve. That's great. That's a great thing. And what's really nice is when you have people in your office who also can link to resources. When I've got a woman who comes in who's just been widowed and she is talking about how sad she is and can't sleep, I don't need her to have sleep medication. Maybe I do, maybe we do, maybe we want that in a society. But maybe what we need is someone to say, you know what, there's a widows group down the street. I know a woman who just lost her husband a block away from you and she'd be happy to spend some time talking with you. Maybe you should just come and talk to me. Maybe the husband drove the wife around and so she has no transportation and her children don't live in town and somebody has to help her find out how to get her groceries. That's what it could look like. That's what it could be, is that we would actually care about the patients and spend more than 10 minutes with them, which would be great. In our
Are you
office.
still asking that question?
I am. You tell me. How would it feel?
I'm having trouble hearing, but anyway, one thing I would think you would treat me, I get sent to a room and I wait 45 minutes for a doctor.
I like it. That's right. Very good. I would agree. How many of you are tired of waiting in the doctor's office? Right? And how many of you are tired of the fact that it's like 65 degrees and they make you be naked? You know how often we tell our staff, okay, they don't have clothes on, you do, stop. You stop doing there. And I
I don't
agree.
know how you do better, but that's
I think you can do better. I really think you can do
scheduling's
better.
gotta be different.
It has to treat each person like they matter. What would it feel like if when you walked up to the desk, people actually smiled and told you they were glad you were there? Instead of like you were bugging them. How odd would that be? Yeah.
Sounds like if things are integrated the way that you say, it would also reduce the stigma of going to get mental health.
It does. Because when you get called to go back, which we might not do that call to go back thing so much, but you're right, because when you're there, your car isn't at a mental health provider's and nobody calls you back saying, you know, so-and-so come back here, we've got to see you for a mental health problem. Now, the stigma isn't as bad, right? Almost all of us who, you raise your hand if you don't know somebody who has mental illness, even defined simply.
Oh, I know.
Yeah, I mean, define it simply, right? We're all on the spectrum. I'm just saying, clearly I'm on the spectrum, but other guests are like that side of the spectrum. But everybody's kind of on the spectrum on something. How silly for any of us to think that we're, what, normal all of a sudden? I mean, physically, mentally, there's not a perfect person in this room. But if we, yeah.
Well, you can continue your thoughts. Sorry.
No, I'd love to hear what you have to say there.
Well, and I completely agree with like integrating. So don't perceive this as I'm talking against it.
Disagree.
I'm just worried about. So we're talking about costs and who's going to pay for it. How do we integrate the costs of our mental health professionals into this cost? Because we're already just talking about delivery, and that doesn't even really include this right now. So how do you make that sell when we already don't want to pay what we have to pay because we have to pay for so many other things?
Well, here was one of the good things. Yeah, go ahead. Group care. That's right. We can do group therapy. The other thing we found in our clinic is though we couldn't be reimbursed for our licensed mental health person because we hired her before she was certified in the insurance companies, is that our doctors and PA and physician assistants could see more people because they didn't spend as much time with any one person who had maybe a mental health issue. So they could direct them to the proper care. And the other thing that we have to think about in America today, what's the ratio of primary care to specialist care in America today? Do you know? It's 40% to 60. 40% primary care providers, 60% specialists. In most other countries, that's been flipped on its head. The average primary care provider under Medicare makes $57 per visit. The average specialist makes $135. Twice. You could pay for 2 primary care visits for every specialist visit. So I'd say maybe we can figure that out too. You know, how do you cut that? And how do you cut the use of services that people don't need? If I do a chest x-ray in my primary doctor's office, why does it have to be redone when I go to the hospital? It's already been done. Why does everybody have to draw that? Yes, sorry.
So you talked about in that one situation that money was saved, but I'm wondering where did that money saved come from? Is there, with the ultimate question of, is there a job loss within the healthcare provider?
Such an awesome question, because you're right, and that's what we're seeing. We're actually seeing that if you have this happen, you might reduce ER visits and hospital stays. Well, who gets unemployed then? Nurses? We'll have to hire them in the primary care offices. But you're right. That's a very important thing. It shifts employment. And those are the kinds of things when we think about this tonight, think about how it hits the whole society. This isn't just an easy deal. And, you know, last week I was yelling about I don't want to pay for fish getting cleaned up down south because it'll affect my retirement fund. Well, I can tell you what. I'll bet a lot of us have Humana and other large healthcare companies in our funds, and it's going to affect its performance because those big companies are going to take a hit. So that's also something to think about. So now I'm going to shut up. I'm going to have Natasha come up and talk. Now, Natasha Askelson is also one of our colleagues at the University of Iowa Public Policy Center, and she has her PhD in community and behavioral health at the College of Public Health and does a lot of work with nutrition and programs for schools and all sorts of other stuff.
How do I advance the thing?
Oh, you have to push this little down button. Yes, you can. Cool. All right.
So I spent my morning, you guys can hear me, right? I'm not as loud as Betsy, I don't think. So I spent my morning with high school students, actually seniors, who only have like 3 weeks of school left, and prom is this week. And I'm supposed to be talking to them about eating school breakfast, and they're supposed to be encouraging their peers through a campaign to eat healthy at breakfast time. Do you think they were very interested in that? Oh my God, they were so much more interested in like the squirrels that were outside. There was so much texting and tweeting going on. So I appreciate you guys are not like jumping out of your seats. None of you seem to be like touching each other excessively the way they were. Thank you. So I'm the odd one. I'm the one who spends my time thinking about how policy and behavior intersect. So I'm interested in how human behavior is related to policy and how policy is related to human behavior. So I spend my time thinking about how we change behavior. So human behavior is pretty complex. And I thought what I'd do is we'd kind of talk about, well, what did Betsy say? What was the biggest influence on our health? Right, which is like one of the most complex things for us to think about. We don't have very good ways of changing your behavior, other than maybe forcing you to do something at gunpoint, or and people, when they're forced to do things, often then revert back to their old behaviors when the gun goes away. So we need to think about how we can address this behavior piece in a way that's sustainable, in a way that we can do it across the country in a way that makes sense. So I want to kind of walk you interactively through an example that I think about a lot. So let's take obesity, which is something that we've talked about some this evening, and think about what are all the things related to obesity? What are the health behaviors related to obesity?
Food choices.
Lack of exercise.
Okay, physical activity.
Food choices.
Food choices. Give me a little bit more about that.
Picking the less healthy, more calorically dense food filled with more sugars and fats, but would be healthier food options, or just not having those food options to choose from, or not seeking them out, or even not being aware that they exist.
Okay, that was a lot. What else?
Could you repeat some of that?
Oh, I'm sorry. You're serious, right?
Some, not all.
You said food choices, you said choosing, I'm just going to simplify it, choosing fruits and vegetables over more caloric dense foods such as potato chips and soda pop. All right? Other things. Genetics.
Depression.
Okay, so mental health issues.
Different medical interventions.
So interventions.
Food-drug interactions. Some drugs increase your appetite.
Some will suppress your appetite.
Okay, so maybe these treatments you might be taking for something might cause you to eat more or metabolize food differently. So complex, right, to figure this problem out. We're going to take one of those behaviors and break it down a little bit more. So we're going to take getting kids to eat fruits and vegetables. So can anyone think of anything that's happened recently that's an effort to make that happen? What's going on in our community? What's going on in the state? What's going on nationally? I hear stuff, but I don't actually hear anything. Blue zones. Do people know what the blue zones is? Yes? Everyone? Okay. All right. What else?
My plate.
My plate. Do people know what my plate is?
No.
You want to explain what my plate is?
It's basically the idea of replacing the food pyramid so that people can better conceptualize what the ratio should be between the different major food groups.
Okay, so when I was in grade school, it was the 4 food groups, and it was this quadrant. I actually was at the National Archives over spring break, and there was actually used to be a food wheel that was like 8 different food groups, and one of them was butter and margarine. they were delicious. And there was also sweets and desserts too. So then we went from the 4-quadrant, 4 food groups to the pyramid, which was never actually tested with an audience and was incredibly confusing to understand how that worked. And now we've gone to my plate, which shows, what does it show you're supposed to have on your plate? Yeah, at least half of your plate every day, every meal is supposed to be fruits and vegetables. What else besides my plate includes oats?
Let's Move by Michelle Obama.
Let's Move. Okay, so is everyone familiar with this campaign the First Lady has got going on? So she's trying to get kids to be more physically active, and she's trying to get them to eat healthier. She invites kids to come into the White House and eat food the chef has cooked. They have the garden in the White House. There's a recipe book that kids are able to submit their recipes to that you can download. What else?
School garden. School garden.
School garden. So school garden is something that's become really popular nationwide. In Iowa, it really hasn't taken off the way one would like to see, but school gardens are a big push.
Free and reduced lunch program? I don't know how the status of how they're doing nutrition.
So does anybody have kids that are in school district? Yeah, so what has changed about school lunch in the last 2 years?
It tastes worse, according to kids.
Yes, I've heard that a lot. Thank you.
They removed the sugared beverages except for fruit juice, and they have changed the nutrients that are allowed and not allowed such that they're healthy but maybe outside of the food. Plus,
So there's been a, go ahead.
They're also talking to the elementary kids of making good choices in foods and eating so many vegetables and fruits a day.
Mm-hmm. So there's a bunch of programs like Pick a Better Snack that's in Iowa that helps kids learn about tasting different vegetables and how you can incorporate vegetables into your meal, like ask parents for vegetables. There's actually a program that uses pester power, which is something that marketers use to get kids to buy, or get kids to get their parents to buy stuff for them. And instead they're teaching kids to pester their parents for fruits and vegetables. That's cute. So the school meals have changed pretty drastically. When my kids started elementary school, actually, I was shocked by how the meals were actually literally the same thing that I had as an elementary school student. And I thought, wow, we know nothing about nutrition in 30 years. That's amazing. But the new Healthy, Hungry, Free Kids Act of 2010 used what we know based on the American Dietary Guidelines to revamp school lunches and school breakfast. But for school lunch now is only 1/3 of the calories that a kid should have. Before there was just a minimum calorie that the school would have to meet. Now there's a maximum that they can't go over, which is a really big change for a lot of schools in rural Iowa, where kids were used to getting seconds, thirds, fourths, especially if they were the football player, or whatever was left over at the end of the lunch was a free-for-all and everybody could have. Now they can't do that anymore. They've changed the amount of fruits and vegetables that have to be offered and the types of fruits and vegetables. So they now have to have green leafy vegetables, which means kids are getting things like spinach and kale that some children have never seen before. They have to have a red vegetable and they have to have an orange vegetable. Everything will have to be whole grain coming in the fall. And they've decreased the amount of protein that is in a meal. So those are pretty big changes, including now offering water has to be offered for free, and it has to be low-fat or no-fat milk, including the chocolate milk. So that's one policy intervention, right, that could change kids eating fruits and vegetables. Does it actually change kids eating fruits and vegetables?
Not if parents don't follow through at home.
There is that issue. If kids have never seen this fruits and vegetable, if mom and dad are saying you don't need to eat it, if I hear what I hear from a lot of parents is, you know, where'd the macaroni and cheese go, or where'd the bread and butter sandwiches go, my kids don't eat rabbit food, then kids aren't trying their fruits and vegetables. So this is a huge policy shift that's happened, but we're not actually seeing a great increase in fruit and vegetable consumption. There have been a few studies that have shown there is some increase, but it's not all of a sudden our kids are really eating healthy. So what else influences whether our children decide to eat fruits and vegetables?
Cost.
Cost, explain that.
There are families who can't afford the cost of produce. Produce isn't as cheap as the dollar menu at McDonald's. And in terms of the type of fullness that they get from the fruits and vegetables and the lasting fullness that they get from that versus the lasting fullness of cheap meat, and breads, you're gonna see it over the long term, they're not gonna feel as full, and they're gonna need to eat again, but the cost can be prohibitive to do so.
Yeah, cost is a big issue, and related not only in what it costs at the grocery store, but let's say I'm a mom and I want to increase fruits and vegetables in my kid's diet. So I go to the produce or I go to the freezer section and I buy, what, lima beans. Well, I don't know if my kids are going to like those. If I serve lima beans and nobody eats them, that's been a waste. That's a huge cost. Or my kids want to try kiwi. I don't know how to tell if a kiwi is ripe or not. So I buy kiwi and I take it home and we try it and it's awful because it's either overripe or it's not ripe enough. That was a waste. So if you're someone on low income, what are you going to make for bets when you go to the grocery store? Are you going to buy produce where you're not sure exactly what it might be or whether it's good or not, or are you going to buy something processed where you know it tastes the same every time? And I've heard lots of stories from mothers who are feeding kids on limited income who say, my kids like fruits and vegetables, but either the produce in the store is not always great, or you don't always know. I mean, how many of you have ever bought baby carrots and they were bitter, like the whole big bag? And the kids aren't going to eat them, right? So those baby carrots were a waste for you, and that was money down the drain. What else besides cost?
Accessibility.
Accessibility. So we got people who live in neighborhoods that have very few grocery stores that have produce or have even a frozen section. We have people who live in rural areas who have limited transportation.
Very early introduction, repeated introduction, and modeling by the parents or caregivers.
Mm-hmm. Those are some things that have been shown to make kids good fruit and vegetable eaters. But let's say you've got a 9-year-old and an 11-year-old, and you're going to make a commitment to fruits and vegetables. How do you undo 9 or 11 years of eating behaviors? What else?
Going off what she was saying, I guess discipline. I guess raising them right from the beginning. Because I remember when I was little, like I wouldn't be able to leave the table unless I ate my vegetables, and now I love vegetables. So I don't know if that has anything to do with it. Plus, like pushing for, you can go watch 10 or 20 minutes of TV if you finish your vegetables, like that kind of disciplinary action.
So parenting is a really interesting thing. So there's all kinds of evidence around parenting styles and kids eating. So we have indulgent parents. That's one style, right? So that's the parent who, whether it's because I'm too harried and hurried and I don't have time to deal with it, I'm not going to argue with you. I just want you to eat something right now, right? And so you're going to give in. There's the authoritative parent who says, come help me make this salad, we're going to wash this together, see, try this tomato, it's really good. Oh, look, you made this great salad, try it, and gets the kid to eat it. There's the authoritarian parent who says, like my parents said, you're not leaving the table until your milk is all gone, and I would sit there for an hour or 2 or 3.
Do you still drink milk?
Oh, I hate milk, it's disgusting.
Really?
And there's a lot of evidence that doesn't work, that kids don't sustain those behaviors. So what we try to get parents to think about is how can you incorporate kids in the decision making around the buying of the food, around the preparing of the food to get their buy-in. But I mean, for those of you who have children in your house now or had children, I mean, how many times a week are you able to incorporate your child in the making of the meal? It's a pretty unrealistic expectation, and now imagine you have 4 children and you're a single mom and you're living on limited income, and they have to go to activities and things, and you've got to go to your job, and you want the kids to eat, they need to eat. So behavior is complex. What else makes eating fruits and vegetables hard for kids, or what are the barriers?
I think sometimes people don't know how to maybe prepare it creatively.
Not even creatively, not know how to prepare it. So some of the low-income families that we've talked to do not own pots and pans. They do not own vegetable scrapers or carrot peelers. So we're starting with, you know, very limited assets and also very limited skills. So not everybody knows what to do with a whole head of cabbage. And some people, I think, take that, you know, we're in this foodie kind of world and think, well, of course people know, but they don't. They don't know whether it's right, they don't know if it's good, and then they don't know what to do with it when they get it home. Because we've kind of lost, you know, our connection to food and how it grows and how we prepare it and where it comes from.
People are spending so much time focusing on children and having them make good choices. I think that they're forgetting about the parents. The parents need education too.
Mm-hmm. So that's something that we've been talking to parents about, like how can we intervene? How can we help you? And parents are saying things like, well, it'd be great if when I was walking in the frozen food aisle, there was a recipe right where the frozen green beans were, and that recipe was easy enough for me to make as soon as I got home, and I would have the ingredients on hand. But our grocery stores aren't made that way, right? I mean, they're made to sell you more product, to sell you more expensive product, but people need like tangible stuff at the moment when they need it.
How big of an issue are food deserts in Iowa?
It's pretty big. The CDC just released a census tract analysis, and so they were looking at whether you had a grocery store or other food outlet, and they weren't counting like a Casey's, in your census tract or within a half mile. And we have a lot of census tracts that don't have a grocery outlet in their census tract. As you know, I go to a place called Comanche, which is on the Mississippi. And I took my students there to look at the grocery store. And the grocery store had maybe 2 bags of apples, a bag of oranges I never would have considered buying, lettuce that dripped, you know that lettuce? And that was pretty much it in the fresh fruit and vegetable section. The frozen section had lots of blue meat. It smelled bad. Some of the undergrads I had with me wouldn't even buy a bottle of pop there because the store smelled so bad that they found it gross. And this is the option that people in Comanche had that was closest to them to go buy food. Wasn't Casey's, but a similar store, convenience store did have bananas and apples that you could get at the cash register.
Does it affect older people too? I mean, if they can't travel, then they'd be stuck at that same grocery store.
Sure. I mean, who are the people left in Comanche?
I think rural Iowa is in crisis.
Mm-hmm.
I came from a community of 1,100 people 10 years ago, no grocery store. And that's typical.
Mm-hmm.
You have to go 10, 15 miles to get reliable food. So
Yeah, I mean, I think all those of us who are here can remember the farm crisis when mom and pop grocery stores were closing all over in rural areas, and rural communities knew when they lost their grocery store, they lost a huge resource. So in public health, we like to think of our behavior not just being influenced by our choices, but by being influenced by the things that are inside me, the interpersonal things. So my knowledge, you know, do I know what to do with carrots that haven't been peeled? My motivation, you know, of all the things I have to do, how motivated am I to make sure that my kids get fruits and vegetables? I got a lot of other things going on in my life. Then the interpersonal things, so this is where parenting comes along. This is where those other issues like the family unit happen. Then we think about things like the community, like you've talked about, like the grocery stores, like the school, portion sizes, eating out. For a lot of low-income families, eating out is going to a convenience store. And you've been in Casey's, you've been in Come and Go, you know what's there for options for eating. There aren't a lot of healthy choices if you want to make them. And then we think about the public policy, the macro level, things like changing school lunches, changing school breakfast. You know, we think about, you know, what are the interventions and how can we impact people at each of these levels? So what are some of those things we could do at each of those levels that would help kids make better decisions and eat fruits and vegetables?
change the things that we subsidize, and also change advertisement.
All right, so she said changing subsidies, food subsidies, right, is what you're talking about, and changing advertising. So those are definitely macro level, public policy level interventions. So, you know, there are people who talk about, you know, we subsidize the wrong kind of crops. That makes people in Iowa pretty upset. You know, there's been more and more work on trying to get places like McDonald's, places like General Mills to decrease their advertising to kids. And there have been some pledges by industry to work on that.
I know an example on a community level, in Illinois, they're working with one of the food banks. They're bringing some local chefs in to help teach people when they come and get their bag of food, like this is how you can prepare your food and learn how to do that.
The food bank brings up a really interesting point that's getting a lot more attention now. What kind of food gets donated to food banks?
Canned goods.
Yeah, what kind of canned goods?
Old.
Yeah, nearly expired canned goods or already expired canned goods. Lots of processed foods. So if you're someone with a chronic illness and you're low income, is the food bank a great place for you to get food that's good for you?
But there are some food banks around the country that are having their own gardens and bringing in donations of a lot higher quality to get away from.
Yeah, there are, and actually Iowa just passed a new tax credit that if you're a local gardener, you can donate your produce to the food bank and get a tax credit, just like you would if you donated your stuff to Goodwill. The problem with that is food banks right now aren't really set up to deal with, you know, 4,000 zucchini in July, which is the reality, right, of what's going to happen, or in August, like tomatoes that, you know, maybe were on the vine a little too long. So that's been a struggle, is how do you process that, how do you refrigerate that, how do you get it to the right people, and then how do you teach people what to do with that zucchini, because if you give someone 8 zucchinis, it might be a little disappointing. So I was supposed to actually ask you this what if question, but I think we're... What if we could dictate your behavior? So my life would be easier if I could just like put a little chip in all of you and make you do what we think is the healthy thing. But that probably isn't the right choice. Do you want to do some wrap up?
Yeah.
I'm done. Thank you very much.
All right, so while we started talking about health insurance, obviously we drifted from there, and I think the point of why we drifted from there is that health insurance only does so much for your health, and we lose track of that, and so much of the discussion about the Affordable Care Act is around the insurance expansion part, which in my opinion, if we wanted to do tomorrow, we could. You know, there's a political will issue and all those kinds of things, but if we wanted to do a Medicare for all tomorrow, the mechanism is there, we could do it. Do we know how to change people's behavior? No. Right? That's sort of the holy grail. Do we know how to change provider behavior in the way that we want to? No, we don't know how to do that very well. And that's the stuff that's really challenging. How do we change the healthcare delivery system so we start focusing on populations of people instead of individuals? That we start focusing on that idea of a primary care medical home with a health home around it, getting the person to the right level of care that they need, instead of thinking that a physician or a hospital is going to take care of a diabetic, or particularly a diabetic with mental health problems who's got COPD and keeps showing up every other week in the emergency room, right? That person needs someone else to help with that behavior change. Not that there isn't a role for the physician in the hospital, but you need to get them to the counselor, to the nutritionist, to the health coach, to whoever it might be to really change that behavior if we're going to have the opportunity to improve quality and reduce cost. And then if you think about that earlier slide where you had 10% of the people using 70% of all the healthcare costs, that's where we really can make some significant gain. But we have to figure out how to do that. In healthcare, we've been so focused on who comes in my door, and that's who I treat, not thinking about how do I reach out and find that person before they end up in the emergency room, before they have a hospital readmission or readmission, and getting them through that care coordination process to these other kinds of things. So that's the real positive, that at least we're beginning to think about a little bit more. Do we know how to do it? Not yet. You know, the behavior change, the nutrition, the things about school lunches, are there challenges with that? Absolutely. Do people like when we do it from a policy perspective? No, right? Again, feels forced. Do people like that we're changing school lunches? What are you finding?
No.
Right? Feels like it's forced. Yes?
Changing the school lunches, but we're not putting any more money into it than we did back in the 70s. And so we're telling schools, well, you have to make it healthier, but we're not subsidizing the right things. And so it's expensive for everyone, including schools, to make those changes and have it include more vegetables, and vegetables are so expensive. And no money's being put into that. And then we're cutting SNAP benefits on top of that. And so I think it's a little bit too pessimistic to say we don't know how to change people's behaviors, because everyone does want to be healthy. And, you know, you can tell people, you know, let's say we integrate medicine, and doctors are telling mothers or parents and kids to be eating more vegetables, but then we send them home and we're giving them less money than we were before. That already wasn't giving them enough money to buy those vegetables. I mean, if you give the people the opportunities, like, they will, I think that behaviors will change.
Marketing already proves that behaviors will change. I mean, if you give the people the ability to purchase these things, marketing has already proven that we can entice people to purchase things. But you have to give them the buying power to start with in the first place. Then it entices people to buy it, and that takes time to let those methods work. They didn't just overnight wake up one day and say everybody wants an iPad. It took time for marketing to entice people and for the strategies to work. It's not going to happen overnight.
No, those are both very good points in terms that we're not necessarily putting all the enabling factors in to make these things happen. We may not financing them at an adequate level. We may not be actually trying in the way that we might want, right? But that's also, I think, a part of the challenge, especially at a policy level. How do you get people to then fund something adequate level for a consistent amount of time to actually, you know, scale things up? So we might know how to do these things at a local level, and we've, you know, have pilots or demonstrations here or there. How do you scale that up to a state level? How do you scale that up to a national level and get people's interest to fund it long term?
And I think you have to think about too, so many of the health effects are down the road, right? Because people want to be healthy, I agree, and yet we've got more college students starting to smoke now than we've had for 20 years. Why would they do that? Why would they spend their money and smoke when they know it's not healthy for them? Because there's no immediate effect. It's going to happen when they're 40. And they don't think about emphysema when they're 40 now. When they're 40, they're going to be sorry, or maybe they won't. They might live to be 100 and smoke the whole time. And I think you're back to marketing.
With any behavior, though, you need immediate consequences or immediate reinforcement to make it work. It's going to prove that years ago. So if you want to make any kind of change, you don't wait down the line for it to and think that it's going to have effects. The effects need to happen now to have an effect on behavior. If gambling were less, the effects didn't occur right away, less people would gamble. But the effects during the gambling and during that reinforcement of behavior, they are immediate. They're now.
And that's why when we tax cigarettes, we see a decrease in the number of people who utilize them. As soon as we increase the tax a certain percent of people drop off and say, I don't want to spend that much to be able to smoke. But it's amazing to watch behaviors. I mean, it seems so easy. And yet every one of us in this room can think of an unhealthy behavior that we've probably engaged in the last 24 to 48 hours. I know I had Easter candy, so okay, I admit I ate peas. I ate peas. Steel peas. I have a peep addiction. I can't help myself. A peep addiction.
So I think what that means is we're not done. The Affordable Care Act is not going to solve all the problems. It's not providing everybody with health insurance, and it's definitely not providing us all with health. So everybody still has work to do, and we'll probably be back here in another 5 or 10 years talking about some of the same issues. Appreciate you all very much for coming out, and hope you have a great day.